Hey everyone, thanks for joining us today. We are really excited to talk to you all about providers collecting revenue during not only COVID, but also thinking about laying some foundation to how to kind of streamline your revenue collections beyond the COVID era. So brief introductions, speaking to you now. My name is Andrew Harding. I'm the Vice President of Customer Success at Rivet Health. And also with us today is Deb Silverman. Deb?
Hi, Andrew. Hi, everybody. I'm Deb Silverman. I'm one of the partner directors at Garfunkel Wild. And once Andrew finishes his presentation, I'm going to talk to you about managed care contracting and how that plays a pivotal role in how you obviously collect your revenue. Take it away, Andrew.
Awesome. Thanks so much. So as we go through the agenda today, there's kind of two primary sections. The first one is focused on looking at patient-based revenue. And then, as Deb mentioned, going to talk through some payer-based revenue and how you can, glean some additional revenue or insights in your contractual relationships. So on the patient side of things, first we're starting to look at modeling the impact and understanding how COVID has impacted a lot of practices kind of nationwide, and then switching into a little bit of patient pricing transparency, about implementing a pricing transparency to accelerate that revenue or that cash collection from patients, and some tips, tricks, and strategies to be a little bit more effective in accelerating that patient cash. So when we think about the overall impact of what the last 8 or so months have meant for practices kind of nationwide, these are some pretty material metrics that most practices have been impacted negatively financially. So that first one, 97%, this is from MGMA, the Medical Group Management Association, that 97% of practices have experienced that negative financial impact, and that's due primarily into many states having mandates to reducing non-urgent and eliminating elective surgical procedures or visits, which drives obviously decrease in patient revenue, since a lot of those are the practice's higher dollar service codes. And then shifting into a little bit different of maybe a procedure mix or a specific code mix, the increase in telehealth visits, and trying to understand how a lot of payers are starting to cover those for the first time. You may start billing those for the first time and trying to understand place of service 2 for a telehealth visit versus certain modifiers that impact your overall financial kind of reimbursement on a claim by claim basis. Those all kind of drive into the impact from a practice. And then not only is it just these crazy COVID times, but there's shifting reimbursement coming from government agencies such as CMS. So we have highlighted on the screen here. It's just from 2019 to 2020, we look at the ASC reimbursement rates from CMS at the national core-based statistical area. And so these are just the top 12 and the bottom 12 of shifting reimbursements. And so obviously there's thousands of procedures in between these that have either not changed materially or have changed. But if your practice bills any of these, you could be sitting in a pretty drastically different financial position than you were last year. So looking at some of those neuroelectrodes, that's obviously a huge increase, going from a little over 9K to 17K. If you look towards the bottom end, those ones that fell into the red, a lot of those are getting cut 30, 40, 50%. And so even despite COVID and reduced patient volume, you may not be doing anything different as a practice, but your gross revenue may be unaffected, your charges, your patient volume may be unaffected, but actual reimbursement rate coming on a procedure by procedure basis is being decreased. So these Medicare evolutions are always helpful to look at, especially as we're rounding the final rule period and comment period is closed from CMS, looking at what is the 2021 impact to your ASC procedures that are going to be done. Are there any big shifts that you should be aware of? And so really focusing a little bit more on the patient side of things before we touch on later on the payer contracts. Implementing pricing transparency has been kind of this shift that's been required to keep up with the lack of either payer revenue or decreased patient volume, is trying to accelerate some of your patient cash. And we think that this starts with trying to be more transparent with your patients about what they're going to owe upfront. And so there's a lot of industry statistics that would support kind of patients are frustrated in their overall financial experience and financial engagement with practices. As the same is true, practices often struggle with collecting from patients. There's been an ever increasing growth in patient AR. 83% of physician practices on the smaller side of things say that collecting from patients with high deductibles is a huge risk for them. and then looking at those kind of the 2/3 of Americans who, they owe their whole deductible or their entire deductible from a specific service, that would be really difficult for them to pay all up front. And thinking specifically the procedures that are done in an ASC, these multiple $1,000 procedures, those often will bump up against 100% of the patient's deductible for these $2,000, $3,000, $4,000, or $5,000 deductible plans. And so, the patient financial component has become, I guess, increasingly stressful for both the providers and the patients alike, as balances, as deductibles, and residual bills have continued to increase. And so I kind of think of, why is this very, not necessarily combative, but sometimes difficult relationship between providers and patients to get paid, and why is it so difficult? And there's this kind of funny mentality that it's like shying away from knowing your out-of-pocket liability up front and being familiar with deductibles and co-insurance and out-of-pocket liability, to be like, sure, bill me 30 to 45 days later. And that's the best case scenario. That's no denials on the claim. That's a relatively quickly paid claim. And so there's this weird bill me later mentality where patients are okay with having absolutely zero transparency into what their out-of-pocket is going to be. And so that trickles down into a lot of residual impacts of, you think about what type of balances, if there's other facility charges, if there's high hospital charges, physician bills are, if your providers are operating the ASC, or maybe they're doing just the physician component of it, these are often smaller than sometimes the facility fees. And so, patients really want to focus on taking care of these big balances, and so they don't have really, high dollar balances going to collections or bad debt. And so it's just this weird mentality mind shift going on in the entire healthcare. And so to combat that, you start by creating a patient cost estimate. And ASCs are really fantastic for this, and and surgeons in general, whether it's your orthopods or your ophthalmologists or gastroenterologists, these providers that do a lot of outpatient surgeries are really good candidates for creating an estimate. And the reason is, oftentimes these outpatient surgeries, you have a good idea of what the patient is coming in for. Total knee replacements, right? Like those have been in outpatient surgery, or ambulatory surgeries for a number of years. And every year, the procedures that can be done in an outpatient or ambulatory setting continues to increase, right? We've seen hips, knees, total joints, even some cardiovascular procedures starting to be done in an outpatient setting. So when you think about creating an estimate, there's really kind of 4 fundamental steps to that. The first is you want to know, as a facility, as an ASC, or as a provider, you want to understand what you're actually expected to get paid from your insurance companies. And so these are generally your contracted rates. There's 2 ways to get these. The preferred is looking at, what is maybe the ASC fee schedule, or the physician fee schedule, or the APC fee schedule. All this is going to give you the contracted rates that you for being an in-network provider. Alternatively, if you don't have the ability to get that, maybe you don't have the capacity for your team to go out and reach out to these payers, or sometimes payers play hardball and give 10 codes at a time or 25 codes at a time, you can use historical remittance data. And historical remits will tell you, hey, the last tens, hundreds, thousands of times that you've billed this specific CPT or HCPCS code, this is what the payer has allowed or paid. And so you can use that as a decent surrogate. So you have to know first what you're going to get paid. Second, you need to know what the patient's benefits and eligibility will return back. And so oftentimes there are service types, specifically the ASC facility is a service type that will say, what are the benefits if this procedure is being done in an ambulatory surgical setting? So once you pair your deductibles, co-insurance, maybe there's a copay, certainly out-of-pocket liability with the actual contracted rates, that's when you come into what is the patient going to owe. And a good system is going to take into account all of those nuanced like payment modifiers. Is it a bilateral procedure? Is it a co-surgeon or assistant surgeon procedure? Are there provider level discounts, nurse practitioner, PAs relative to a physician? So a good estimate system will take all that into account and that adjudication logic into account and be able to spit out a very clear and transparent patient responsibility. So insurance will pick up this much. The patient will likely be left with this much out of pocket, and then delivering that in a modern and friendly platform to your patients. So kind of one way that we think about doing this is actually pairing up your estimate on your left side and a text-based or mobile-based or web-based friendly platform. So one of the very common ways of doing this is portals. A lot of your EHRs or practice management systems provide access to specifically to portals. But you want to kind of think through the process of creating an estimate. So this is just like a Rivet overview, and there's certainly a lot of different ways that you can go about getting this, but you want to make sure that you know what is the patient coming in for. That's obviously, you need to start with a good idea of a CPT code. And generally that's going to come from either referrals or authorizations or pre-certs, that when you're reaching out to the payer, you can start with this is what's coming, the patient is coming in for, and then run through the allowables, assigning benefits. And then we love text messages, right? There's a pretty black and white area on what you can and cannot do with a patient in text messages. So be flexible, try and meet the patient where the patient is going to be most often. And in this day and age, a lot of that is on their phones, on their computers. And so that's kind of the estimate process, in a nutshell. So shifting from simply, sorry about that, from shifting away from the upfront to just accelerating patient cash overall. So these are some quotes, I'd say, from a few of Rivet's customers, that as we query them about what are your biggest pain points, what do you see as issues, a lot of it is patient AR focused. And so this first one is, for the first time in my experience managing a practice, our patient AR is actually greater than our insurance AR. And that kind of goes in line with the the second one there as well, of looking at patient AR over 90 days is now 40% of our total open AR. And those two are just like speak to the growth of high deductible plans, of patient residuals. And I don't have the slide in this deck, but there's been an over 200% growth in high deductible health plans over the last decade. And so you look at all these procedures that are being done, are now, most of them are going to an entire patient's deductible. So that explains where kind of this ballooning patient AR is. And then this hypothesis or theory is collecting from patients will continue to be a threat to the independent physician practice. And not necessarily just even physician practices, but physicians as surgeons in an ambulatory surgical setting. There are oftentimes several $1,000 balances from these facility fees. Trying to collect on those is not always easy. It takes multiple statements, sometimes multiple phone calls. And so, starting to reprioritize how you think about patient AR as a revenue generation lever is going to be a bit of a mind shift, because it's not all about the insurance anymore. And so leading into what metrics are going to be impacted by this. So if you develop a good upfront collection process, or at least an upfront estimates process, you're going to drive up your point of service cash and residually your total patient cash, which is going to have a positive impact down the line of reducing your open patient AR, definitely decreasing the bad debt write-offs. So whether it's 180 days, whether you write them off at a year, your bad debt write-offs are going to decrease. And then your dormant patient accounts, which I kind of define dormant patient accounts as any patient balance that has not had a payment in over 60 days, is starting to be kind of look at that risk of, oh, you might not get collections, or you might not get a patient payment on this account. And then a better financial experience is going to lead to better financial engagement from the patient, which overall makes for a better patient satisfaction, or better patient experience overall. And so walking through kind of the process overview to accelerating patient cash. So we mentioned it starts with communicating balances early on. So the best you can do to communicate cost pre-service is going to put you in a better position financially. And a lot of the practices that we talk to, they're saying, well, I'm nervous to implement an upfront estimates because I don't want to scare patients away, or I don't want them to be worried about what the residual balance is going to be. Well, if you think about it, if a patient's going to be concerned about covering their deductible or their cost after the visit or before the visit, that's not going to change if they get a surprise bill 30 to 45 days later. So as a practice owner or practice manager, I would like to know that information as early as possible, so I can start having the financial discussion with our patients and start looking at either alternative options or establishing payment plans, or maybe we have financial counselors that can help convert patients onto, maybe they're uninsured or have low coverage. There may be plans that your financial counselors can help the patients enroll in. And so knowing that information will help mentally prepare the patient, generally about 2 months before they get their first statement. It's going to help prepare them financially for what's to come from a residual balance. So thinking from a process standpoint, so this is a very, very generic patient collections process, right? There's clinical care, it goes through insurance billing, insurance adjudication. Generally that's taking 2 to 3 to 4 weeks. And then they get into this just like statement cadence that once a month, a statement goes out and it says, this is what you owe. And sometimes it ages it from 30 days to 60 days to 90 days. And then at some point, generally like a collections or pre-collections letter is sent. And if there's no payment, it goes to probably bad debt. Maybe you have a third-party collections agency. And you think about the number of financial touch points. There's 5 notices sent, 0 interactions. So you add in a slight tweak to that, and you start to create more financial touch points and more interactions. So after insurance adjudication, instead of just going statement, 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 letter, you're looking at statements, calls, statement, final calls, and those are all tailored specifically to, sometimes it's referred to as Dunning levels, but generally it is risk level associated with that balance. And you can tailor the tone, the text, the conversation in those phone calls specifically to where that balance is from a risk factor. But even that, it's only 5 notices and 3 interactions. So you gotta start to think of, well, what if you could just like drop your current process and design one from the ground up? And these are like, in the world of marketing and sales, you know, the touch points are key, especially as you think about the value behind every good touch point, right? So it's not always just about quantity of touch points, but coupling quantity with really good insights and quality is going to drive better financial performance. And so this is just like what if you could design your revenue cycle, your patient revenue cycle like this? It starts with an estimate wherever possible. If you have a good idea or understanding of what that patient's coming in for, give them an estimate. Let them know, hey, this is our in-network allowable. Like, this is your benefits. Sorry, I think my network cut out real quick. But this process is really just an overview of, what if you could add more engaging touch points throughout your entire revenue cycle process? And with the advent of better technology comes the ability to, at scale, send financial reminders via SMS or email in a HIPAA compliant way without, obviously without abusing things like the Telephone Consumer Protection Act and a different legislation or regulation that protects patients from getting just inundated with calls, texts all the time. And so you think about and you compare this has 6 notices, it has 10 interactions, and it has 3 times the connection points than a statement-only process. And so this is just really like in theory, if you could roll this out, you will improve your collections drastically. And so kind of flipping forward into, a little bit into, overall paying bills in general has changed, so should your process. You think about like paying for cable, internet, TV, utilities, like those public utility companies have started to adopt more flexibility, online web access, bill pays, electronic payments, even pay by text for some utility companies. And healthcare is really just a laggard when it comes to picking up those better processes. So I really break it down into, patients paying for bills can be optimized in 3 ways. Simplifying patient understanding of bills, standardizing your payment options and rates, and then making it really easy for your patients to pay. So the funny thing about this slide about statements being hard, when you Google like patient-friendly statements, these are like at the top of the list. And if I look at these, I'm like, these are super confusing, and I've been in healthcare my entire professional career. And a lot of patients don't necessarily understand the incredibly dense healthcare jargon of in-network, out-of-network, EOBs, CPT codes, HCPCS codes. And so they just cram a lot of dense information onto these. And if you try and pull things out, oftentimes it leaves gaps in explaining to the patient what really happened and why is this relevant for you. So number one, looking at simplifying your statements. If you work with a statement vendor that allows you to customize your statements, like think about bringing in a creative or product designer that can think about what does the patient really need from this, and how can we consolidate things without adding confusing information onto this. So statements, healthcare statements specifically, not easy. Try and make them a little bit more easy for patients to understand. And then the ability to understand what are my options in paying for care. So you know, I've got two little girls, and so you know we've had to cover bills for both of them from deliveries. And you know, a lot of times it's like, I'd love to pay over 3 months, or you know, get creative with my options, but no one really advertises what are your options to pay. Are there formal payment plans? It's usually much later in the revenue cycle process that patients have to ask, like, hey, I can't meet my, you know, I may have $1,200 out of pocket. I can't meet this in bulk. Are there ways that we could get around this? And so being transparent with what are the options is going to be really helpful for your patients to kind of directly approach. This is what I can do. It is in line with what the facility or the ASC or the physician practice is able to accommodate from a payment flexibility. So this is just kind of one example of how we set up automated payment plans that, you know, the practice with ASC defines the upper and lower bounds. So maybe it's 3 months, maybe it's 6 months for a payment plan. And within those confines, the patient can self-select what their term and rates, and even things like payment date goes a long way into being a patient satisfier. Like, you know, for those employees that get paid, maybe they get paid monthly. My spouse used to be a teacher, and you get the monthly paychecks. You know, having bills come out at that time was a lot easier than maybe closer to the end of the month type of thing. So simplifying how patients can pay, and then certainly make it easy for patients to pay. So just a few weeks ago, my 3-year-old little girl fell and cracked the back of her head open. So we had to go to urgent care, get some staples. Fortunately, the bill wasn't too bad. We were in and out, and you know, it was a great clinical experience. But a few weeks later, we get the urgent care bill, and I, you know, want to log into my portal, but I don't remember my registration code from the first EOB that I got 2 years ago. So I don't know how to get back into my portal. I try to make a phone call, but I'm a busy guy during business hours. So at the end of the day, when I have time to catch up on things, oftentimes the billing office is closed. And so the amount of friction that it was just to pay a bill, knowing that I wanted to, in good faith, pay for my outstanding balance, was surprisingly difficult. So, you know, modern payments should be as easy in healthcare as they are in just about every other industry. There's mobile pay, there's web pay, there's a handful of different payment financing options like HSA, FSA, debit cards, credit cards, as well as like storing card on file for auto payments, right? This great experience would be, I walk out and say, hey, you know, Mr. Harding, we have this card on file for you. Can we go ahead and bill? Great, like that's super easy for me, zero friction. And then, you know, you mentioned the payment plans, but it's a big patient satisfier to be able to determine what day of the month, what is the amount? Can I pay multiple times in a single month? And so patient-driven payment plans are a huge patient satisfier. And then certainly we don't ever forget the kind of the more classical avenues, because there will always inevitably be the patient population that likes to pick up a phone call, especially the kind of the older population that may be retired and may not be working during normal business hours and have the time to pay for their care at 10 a.m. on a Tuesday. Provide that phone line, right? Portals, if you can make it a seamless process so the patient doesn't have to remember some unique code from 2 years ago. You know, a great patient experience is self-serve portals that also generally include clinical information. And you're probably never going to get away from your point of service collections. It's been a little different these last few months as we've seen more kiosks, more at-home documentation, but your point of service is really valuable for your patients as you have that direct face-to-face relationship that you're working with them. Just kind of wrapping up here on the patient component. So the last 2 slides are really on like starting to identify at risk and maybe a few quick drills that you can maybe clean up your open accounts receivable. So this is how I define kind of some at-risk patient account balances. So the first and foremost, looking at balance flags, then you look at transaction flags, and then these things that, you know, Dunning level is a pretty common term, but think of it as just generally risk level. You know, if a patient balance is 60 days, there's risk, but it's pretty low, right? There's a good chance that you'll be able to pick up that payment in due time. Once it kind of hits that 90-day mark, you've probably sent 2, maybe 3 statements at this point, and the patient hasn't paid anything. You're starting to think, hey, something might be awry with collecting from this patient. And then once it hits that 120 days, you've definitely probably sent 3 statements, maybe a letter, maybe even a pre-collection letter once it's reached this age. And they're extremely high risk if there have been no payments on the account. And so that's how I generally would stratify your balance flags. And anything over 120 days without a payment is extremely high risk. It's a likelihood to be written off to bad debt, sent to the third-party collection agency. You can also look at transaction-based flags. So if you have an auto payment system, if there are multiple payments that are failed, like that's kind of a red flag to me that either funds aren't sufficient enough to continue to pay for that care, or just something else is maybe going on, right? We understand maybe one failed auto pay, being cards change, addresses change, but once you resolve that, if there's another failed auto pay, that's kind of a ding, red flag, something might be going on. And then looking at residual balances, so obviously multiple patients, multiple balances in bad debt or collections or that kind of extremely high risk bucket is probably a good leading indicator that patients probably might not pay their newer bills either. And then last but not least, looking at the risk levels, there's a lot of different strategies when you're stratifying how your patient account reps are collecting on balances, but make sure it's consistent and your reps are working the same type of accounts with different risk levels. And so, your 10-day-old balance probably isn't nearly high risk as your 90-day balance. And so make sure the team is focusing on the right type of balances to get the highest yield from your accounts. And so a couple maybe tips or tricks that we found helpful generally to make sure your team is working high yield component or high yield balances instead of just clearing off things that we're going to get paid anyways. First and foremost, clear up your AR. Sometimes it hurts, but moving balances to the appropriate bucket is going to be helpful for your AR team. And one little drill that's sometimes helpful is matching a patient credit to a patient debit. And so a lot of times it's either unapplied or misapplied cash that is sitting on the wrong encounter or wrong account that goes to this, $50 payment here matches a $50 debit on a different patient's balance. You can match those up pretty effortlessly. And then same thing, even if it's not a perfect match, if there's a credit or an overpayment on one account, you can move that money onto a debit balance that's starting to age out and kind of clean off some patient AR there. Looking at low-hanging fruit, right? Kind of the last-ditch effort, maybe the Hail Mary around, hey, if you can pay today, it's the one-time prompt pay discounts on balances once they reach 120, 150, 180 days, because that 10 or 20% discount is definitely going to be more cost-effective than what the third-party collection is going to charge you if they're able to successfully collect. And then last, kind of thinking out financial or foundational progress, like before you really implement anything, whether it's upfront estimates, collections, a change in your revenue cycle, or practice patient collections process, like engage with all your stakeholders. That may be the executive team. You may have like a dyad ownership between physicians and executives. Just align with stakeholders and then set goals, right? One of the most easy goals to set is the upfront financial transparency goal. Say, do we want to create estimates? If we're creating estimates, how much do we want to be able to convey over to our patients? So that kind of closes it from a patient standpoint. Shifting gears a little bit to the payer side of things, this is now a great time as we approach the end of the year, getting ready for a new contracting period next year. Kind of turn things over to Deb to talk about payer contracts.
Thanks very much, Andrew. That was really great. I have to say that I have often had conversations with clients who kind of feel somehow remorseful or they don't really want to collect patient cost share amounts. But bear in mind, you are contractually obligated to collect those amounts. You're entitled to them. And especially with these high cost deductible plans, individuals have elected to pay lower premiums in order to have higher cost sharing amounts. So they're responsible to pay this money and you're entitled to collect it. So don't be shy about it. And I agree wholeheartedly, providing an estimate up front, and if you can get the payers to agree with you, it would help you along and tell you exactly what the patient cost share amount should be. It's actually a great thing. So thank you, Andrew. I learned a lot. And now I'm going to talk a little bit more on the insurance side, where it's sometimes a little less out of your control, but let's see what you can do. So with that, I have to click. There we go. There we go. Oops. Okay. So usually the first thing that we talk about is whether or not you're going to participate in a plan. I'll talk about negotiating the contract. We'll look at some key contract terms. And then we're going to talk about how do you avoid some of the pitfalls in managed care participation and either pursuing dispute resolution if things don't go well. So deciding to participate. I used to have a slide that said to participate or not to participate, that's the question. I don't think that's so true anymore. And really, with respect to ASCs, there used to be a host of out-of-network models. I'm seeing that disappear, but for each individual ASC, it could depend on where you're located, and you really have to do the analysis. Do I need to participate in a particular plan? Do I need to participate in all the plans? What does it look like? What's my market? Who are my patients? Can the patient elect to use an out-of-network ASC? If a patient has an HMO product, all the Medicaid managed care plans, they don't have any out-of-network benefits. If you're looking more at a commercial, more upscale plans, form in a preferred provider organization or PPO, there usually is out-of-network reimbursement. So you really need to look at it on a payer-by-payer basis, and you could have different strategies. You may say, you know what? I'm only going to participate with a couple of commercial plans at first and see how it goes, and I'm going to stay out of network for the rest. Also, if your surgeons are participating, technically they're prohibited from referring to an out-of-network plan, and this can be a little bit dicey, especially if they've invested in the plan. The plans look very carefully at referral patterns, and I have represented physicians who are participating with the plan and continually referring to an out-of-network ASC, and then they've gotten thrown off the plan. So it can happen. Let's move on to negotiating the contract. Often you have to ask, am I in a position to negotiate? Because in negotiating a contract, it can be a lengthy process, it can be costly. Legal reviews, which we do all the time, and I try to be practical about it, but they cost money. And sometimes we can spend hours, preparing a beautifully revised contract with lots of protections, submit it to the plan, and they'll come back and say thanks, but no thanks. So when can you negotiate? And essentially, it's it's true with every type of negotiation. Who has the power to negotiate? And you essentially start at thinking, well, I don't have any power. The managed care plans typically have all the power, and that actually may not be true. ASCs, if they are offering plans a lower cost alternative to a hospital setting, or that you are an out-of-network ASC and you can now start to drive business in-network by doing a contract, you have more power than you might not think that you do. And you don't really know till you start to engage with the plan. So when you are negotiating with the plan, you want to kind of understand what you're looking at, and you want to make sure that you are looking at those areas where you can actually, that really matter to you. Let me just back up for one sec. I just want to talk about, in terms of what I'm seeing more now also, is the type of contracts that ASCs are doing, which involve value-based. And in an ASC, I'm looking at risk agreements where you're doing bundled payment arrangements. That's really becoming an area. If an ASC can do bundles on orthopedics, hips and knees, bariatrics, I'm starting to see sleeve gastrectomies move towards ASCs. That's a whole nother ballpark, or should I say whole nother ball game for an ASC in its negotiation. When the plan can see business moving away from a higher cost setting like a hospital to an ASC, they are very interested in negotiating. Moving back to pitfalls. The last bullet that I have on this slide really talks about establishing a cordial relationship with the person that you're negotiating with. It helps. It really helps to develop a rapport with the plan representative. I'm not one of these people who thinks that all managed care plans are evil, although some of my partners believe that they are, and some of you may feel that they are, but they're people and it's business. So I tend not to paint them with a dark brush, and you develop relationships, and it really does help in having a relationship and developing a contract that you can live with. Also understanding what you're looking at when you're negotiating a contract. Yes, there's the participation agreement, which has lots of terms and conditions. There's the compensation schedule, which arguably is the most important piece of the whole negotiation, what rates you're getting paid. There are the policies and procedures that live outside of the contract and which the contract will require you to comply with. Sometimes you don't even know what's in them. So that is key as well. And then there are regulatory appendices, which apply if you're dealing with a Medicare Advantage plan or a plan that's licensed under New York State or New Jersey or Connecticut or whatever the state laws require. So those, there's usually not a whole lot of negotiation, but don't forget about them because you want to make sure that the plans haven't thrown in any requirements or burdens on you that really are not regulatory in nature. Let's talk about some key contract provisions. And I'm actually starting with what you might think would be the last provision. I'm starting with it first. Because at the end of the day, if you can get out of a contract at any time, you can probably risk entering the contract on the front end. Sometimes you can get out without cause at any time. Sometimes the plans link it to an anniversary date. Sometimes the agreements will auto renew and you keep going. And if you miss that termination on renewal, you are in for another year. You can miss it by a day and you're in for another year. I've actually represented a surgeon who was non-renewed, except the plan missed it by a day and he stayed in. In fact, he's still in and it's now 2 years later. So it's important to understand the rules of getting out. All right, this is probably the most important piece. What are the services that are included? With an ASC, it can be simple. It could be just the facility fee. It could be the facility fee and the anesthesia service. It could include the surgeon's services if you're moving towards a bundled payment. You also need to know what are the payment policies in effect. Are you being reimbursed under APC methodology under Medicare? Are they following strict Medicare guidelines? Or can they kind of say, yeah, it's consistent with Medicare, or it's, you know, consistent with Medicare plus our own homegrown policies, our own grown payment policies. You need to understand how you're being reimbursed. You also need to know if they're going to change the reimbursement. Are they going to change it based on changes in CMS methodology? Are they obligated to pay you when the change becomes effective with CMS? Or can they say, well, when we load it, which could be 60 to 90 days after the change comes out, and we've paid you claims prior to the load date, but after the effective date, are they obligated to reprocess and pay those claims? The answer is typically no. Plans, once they pay a claim, they do not want to go back and touch that claim again. So it's important to understand that. Also, if you're being reimbursed in accordance with Medicare methodology, does the 2% sequestration reduction that fee-for-service Medicare has implemented, which is currently because of COVID on hold, but I expect that to come back, is the fee schedule subject to that? Technically, if it's not in the contract, the plan cannot apply that 2% reduction. They do it anyway. So here's where I want to touch on some of the points that Andrew stated with respect to patient recovery. The idea of getting an estimate upfront is a great idea because the plans will often tell you you cannot collect the money from the patient until the claim has already been processed. They say that because of claims in the queue, you don't know what has already hit the deductible amount, and they're very sensitive to this. So in looking at the contract with the plan, I like to put in that you are affirmatively allowed to collect the deposit if you or take a deposit as to patients' deductible and cost sharing amounts. If you take too much, you have to quickly return excess. And quickly is not 60 days. It should be within 2 weeks if you can do it. That their plans are very sensitive and some plans are more sensitive than others. So this is something that we always try to get in the contract. Sometimes I tell clients, sometimes it's easier with this, easier to ask forgiveness than permission. But I do know, for example, Empire Blue Cross Blue Shield has just come back to one of my clients and said, you cannot collect deposits. You don't have the right under your contract, and we absolutely refuse to let you do this. So they backed away, but they didn't terminate the contract. Now, the idea with what Andrew talked about by getting a credit card up front, and once that claim is processed and you know the exact amount, putting that through the credit card, I think is a great idea. Also, in terms of your own claim submission, things that put a drag on your own revenue collection, is you got to follow the terms of the contract, right? If they give you a short window to submit that claim, submit it. Under New York state law, you have 120 days to submit a claim for a commercial plan and 90 days for a Medicaid managed care plan. Medicare Advantage says whatever's in your contract, and usually they can put in some pretty tight timeframes. Now, in the perfect world, you're submitting claims yesterday, right? Because the faster you submit the claims, the faster you get your revenue. But that's not always the case. So you really have to see what's in the contract and make sure you submit those claims timely. If the contract says 120 days and you submit the claim on the 121st day, they don't have to pay you. The other side is when you get the payment, make sure you know that it's accurate. There's some really good software out there that you can confirm that you're getting paid what the contract said. And I'm going to speed up. There are policies and procedures. You need to understand them. They're online. They're on the web. Make sure you understand what's in policies and procedures that could impact how you provide services to their members. Most of this is on utilization management. With ASCs, it's pretty simple. Get pre-authorization before you do anything. If you don't get that pre-authorization, the likelihood is you're not going to get paid. Notices, it seems basic, but just make sure you know where the notices are going to. In standard managed care agreements, the plans can amend on notice, and you have 30 days to object. And if you don't object, you're stuck with what they've done. So make sure you can follow where the notices are going. Amendments, again, like I said, they can be unilateral. You want to make sure that you are seeing these amendments and understanding them. Ideally, if you can negotiate the contract, you want to make sure that any amendments, especially those that impact rates, require mutual written agreement. And if you have negotiated the contract, they should not fight you on that. Okay, now we, quickly on dispute resolution. You were able to negotiate a fair contract, you got decent rates, and suddenly you're seeing that you're not getting what you got, you're not realizing the revenue that you expected. Why? I've given you a list of things that could be causing the problem. Payers make mistakes, and sometimes it's as simple as they've loaded a code incorrectly. A phone call to that payer rep that you've established a good relationship with can fix that. There could be confusion or ambiguity about the rate. You didn't get pre-cert, you were late. They've asked for some medical records. You either didn't supply them or they didn't support the services that you provided. There could be audit activity going on that you don't know about. The laws are very favorable to the plans in setting up prepayment reviews, and they can stop paying claims until they receive medical records. And then, of course, if you fail to appeal timely, there are all these timeframes that are in the policies and procedures about appealing that you need to follow. You miss those timeframes, you are out of luck. Okay, so now you have these claims issues, and there are timeframes, as I mentioned, with respect to appeals that have to be followed. You need to understand your claim submission rules and kind of drill down as to where the mistakes are happening. If they're operational mistakes, try to fix them. If some things are just fundamentally unfair, reach out to the plan. I have gotten clients paid where a box of claims had never got processed. The plan got their premiums, the patient got their medically necessary covered services. Why should my client not get paid for those services? So sometimes you can kind of, beat your chest a little bit and get paid. But for the most part, they follow the rules. It's their bat, their ball, their rules, and they're going to stick to it. However, there are times when you've done everything right and they're still claiming that they don't owe you the money. So if you have to escalate an issue, what do? You got to document every phone call that you make. Who did you speak to? When did you speak to that person? You're going to show that you followed all the contracts. You're going to follow the processes in the contract and the policies and procedures. You're going to engage in cordial conversations with payer representatives, and you're going to involve legal counsel if it makes sense to. If you're complaining about a bill for $5,000, most lawyers are not going to be able to help you in a cost-effective manner. But once that number starts to edge up into the 5-figure range and beyond, do involve legal counsel. A demand letter can be helpful. You can arbitrate if necessary. Most of these contracts these days have mandatory arbitration provisions. Sometimes you can agree to go to non-binding mediation if you can get the plans to agree. But don't sit back, don't be shy. They don't view you as like a bad provider if you try to get what you're entitled to. And there are rules that protect them from taking retaliatory action against a provider for enforcing their contractual rights. So here's a little bit about Garfunkel Wild. You can look at it at your leisure. And we thank you very much for joining us today. I think I came in maybe a couple minutes over. It's been a pleasure working with Andrew, getting this ready for you. We are going to be having a Q&A at 3:30 on November 18th. We'll be on and answering your questions as they come up. So thank you, everyone, and stay healthy.
Thanks.